secure the chest drain by skin stitches bracket mattress and dressing over the chest drain. Okay, so this is what you are required to do. The step 8, bag care. The bag care is very important. If this is the chest, the water seal drainage bag has a few rules I have taught you in the thoracic class. The distance of the bag should be at least 1 meter from the bedside. Number 1. The water level, the minimum water level must be maintained. The minimum water level must be maintained. Okay. The next part is there is an exit for air that must be open. Examiners will like these 3 points to be mentioned in an exam. What are the bare minimum 3 things that you are required to see after a chest drain has been given? This bag is called as a water seal drainage bag. Now, after we have seen this one, what is important is that this water seal drainage bag, remember that this water seal drainage bag, what you are required to know is there is an exit of air which must be opened. There is a minimum air water level and there is at least 1 meter that you are required to know. Okay, so these are the 3 things that examiners will like to ask you. And the next step is always do a check X-ray after a drain placement. If you have completed writing, please tell me. Completed?
Done, sir.
Done? This is all things. Let us come to the complications.
Sir, can you repeat this thing?
Keep the bag 1 meter below the chest, number 1. Number 2, the water level should be the minimum thing that must be maintained in an intercostal chest drain. In the intercostal chest drain instrument class, I will be showing you how does an ICD bag look like. And finally, there will be an exit for the air. That exit for the air must always be opened. 3 things, sir.
Okay, sir.
What are the complications of an ICD placement? So, complications number 1 can be injury to the surrounding structures, which could be A. Intercostal vessels. How to avoid any injury to the intercostal vessels? Remember that if this is a rib, where is the intercostal vessel placed in the rib?
Lower border.
They are placed in the lower border. Very good. So, examiners will like to ask you, where have you placed the incision? Sir, I have placed the drain always at the upper border. So, if you have placed the drain at the lower border, then you can injure this. So, this is no and this is right. Always remember that intercostal vessels can be injured. Okay, and this is what is important. Number 2, if you are anterior to the anterior border, you can injure the pectoralis major muscles or the breast in a female. If you are posterior, then you can injure the nerve to the serratus anterior. So all depends upon which position you are. Number 2 is the tube can get blocked. The tube can get dislodged, blocked or dislodged. Anything can happen with the tube. So these are the common complications that are there. There are many other complications that you are not required to know. In an exam, examiners will like to ask you these ones only. Please tell me if you have completed. We come to the last point of an ICD gel placement.
স্যার এই রিবের উপরে দিলাম কিন্তু উপরে যে রিবটা আছে তার নিচে তো ভেসেলগুলো আছে।
Sir, very good question. That means that you are on this point now. Hence, there is that upper rib vessel. That's a very good question. Upper rib vessels are always along the lower border. देखो? So you are not required to go to the lower border. You are always going to go to the upper border of that. And hence I told you, please put a finger. If you put a finger, what is the advantage that you have done while you have put the finger? Sir, you have dilated the road. The tract that is made, that is dilated, and you can put in the tube easily. That is the advantage of giving in the finger. Have you completed, sir? Completed writing?
Yes, sir.
Good. Job done. So this is all things that are done. The last point is, I should have not made that line. The last point in this is when to remove the chest drain. When to remove the intercostal drain, ICD. Answer is very simple. There is a clinical evidence of lung expansion. How do you know there is a clinical evidence of lung expansion? Sir, on auscultation. This is something that you have been taught in medicine. Number 2, there is a radiological evidence of lung expansion. That means the X-ray is also showing you that the lung is expanded. These are the only 2 things to remember when we do like to take out the chest drain. That's it. So please remember that chest drains are not taken out on days. It all depends upon what is the purpose and has the lung expanded or not. If the lung is not expanded, don't take out the chest drain. Things can get really bad then. Okay. Complete?
Yes, sir.
So these are again very commonly asked things in your exam. So you have done with 3 major or 3 common of these ones. Talk about the rest of them. We'll talk about abscess and hydrocele and take a break after 5 to 10 minutes. Injections and catheterizations. Talk about injections and catheterizations. Okay. The next of the operative 4 or operation 4 in the minor. The operation 4 in the minor are injections. So now injections are taught in pharmacology and I think my role is very minimal. You are asked about the various routes of injections and examiner will ask you to start with an intravenous route. Now, what are the drugs that are given intravenous? Okay, remember that drugs that are given intravenous can be, to start with, proton pump inhibitors. They can be any other drugs that are given. Yes, sir. IV fluids are routinely given. Blood is routinely given, but these are not injections. These are infusions. Again, pharmacology. Infusions are liquids that are given over a time. Injections are short liquids that are given over a limited time. So I am not teaching pharmacology. Now, some agents like potassium chloride and noradrenaline are always given in central vein. Always remember, and that also in a dilution, because these are required to produce a severe vein wall injury. Hence, please remember that in a clinical practice, never give a pot chlor injection or a NORAD in a peripheral vein. Things can get really bad. So, what is important is potassium chloride and NORAD are given in a central vein, which you are not required to know in MBBS. What is a central vein catheterization? This is not in your syllabus. Intravenous injections, the usual site of an intravenous injection are veins in the forearm. The particular steps of concern in this one is to make the vein prominent or vein selection, which can be usually the antecubital vein, which is usually a very constant vein, and the veins on the flexor aspect of the forearm. That's all. The next of the steps includes, so step number 1, if this one is this, the step number 2 is to make the vein prominent by application of a tourniquet. The next of the steps in concern will be antecubital, make the vein application with the tourniquet. Next is aspirate the vein to confirm the location. Step number 4, open the tourniquet. And step number 5, slowly inject the drug. I have forgotten the step called antiseptic dressing and dripping, but I think that is something that you can mention very clearly. Just tell me when you have completed writing. Hello? Done, na? Good. The next of the steps of an intramuscular injection. Now, that is something that is not that details to be known about. When you talk about an intramuscular injection, you are only required to know the sites. The technical sites of an intramuscular injections are usually bulky muscles, and in the forearm we usually select the deltoid. Okay, and in the deltoid, always remember, if this is the arm and this is the orthopedics people will be teaching you, this is the olecranon and this the triangulation. Always divide this area into 4 quadrants. If this is the scapula, that is something that I want to draw. And if you have made this quadrant, the 4 quadrants, this is the lateral side, this is the medial side. Always remember that the logic is very simple. Give all injections in the upper outer quadrant. Why? Because there is a nerve on this quadrant. Can you tell me what is the nerve that I am trying to draw?
Axillary.
Not exactly, sir.
Radial nerve.
Exactly. This is the radial nerve that is spiraling around. And those of you who have said axillary nerve, the axillary nerve will be in this location. Okay, which is going to wind around the neck of the humerus. So the nerve that goes, please look into that the nerve in the upper inner quadrants of the arm are the radial nerve, the blue colored structure, and the green colored tube or the structure is the axillary nerve. So all intramuscular injections has to be placed in the upper outer quadrant. Please remember that. Number 1. Number 2 is that, so this is something that you are required to know in that. So this is called as the steps of intramuscular injection. Okay, so please remember this point. Next one is if the drug that you are injecting is a known irritant. Example, if it contains an alcohol as a part of an agent, or if it contains, say for example, other carriers, example aluminium hydroxide. So these drugs are very irritant, and these irritant drugs are always given in a bulky muscle like that of the buttock or the gluteal muscles. So if you are giving it in the gluteal muscles, again the same logic of the four quadrants. That means if this is the posterior superior, this is the iliac crest, and this is the crease of the buttock, and this is the sacrum, then divide this into four quadrants. And if you have made the four quadrants, always give the injection in the upper outer quadrant. Can you tell me why will you give it in the upper outer quadrant? Because the sciatic nerve is in the upper inner quadrant. Examiners will ask in surgery exam, can you name me a drug that is given in the buttock as an injection in your daily practice? Things that are given in the ward. Can you name any drug that is given? Magnesium sulfate. Very good. Magnesium sulfate. Very nice. Thank you very much. Okay. Why, sir? Why is magnesium not given in the hand? Number one, because of the volume of the drug. Number two, because it is an irritant, and hence it is given in the buttock. Anything more that you know? Where is injection diclofenac given? Remember, injection diclofenac is better given in the buttock rather than being given in the arm. If you are giving 1 ml or more, it is preferably given in the buttock because it contains a carrier as an alcohol, which is extremely irritant. Okay, so please remember that these things are there. So these are all the two things to remember in an intramuscular injection. And come to the next type of an injection, that is something called as a subcutaneous injection. Now, when you talk about the subcutaneous injections, these are less seen in the surgical side, more on the medicine and pediatric side. Remember, subcutaneous injections, the common sites are always the anterior abdominal wall fat, because the anterior abdominal wall contains a good amount of fat, or the outer aspect of the thigh. Can you name me some drugs that are given in the medicine and surgery ward as a subcutaneous injections?
Insulin.
Very good. Yes, insulin. Very nice. Okay, anything more in cases of emergency like an anaphylaxis? Adrenaline. And someone said that, and I really appreciated this. These are all asked in Viva. Are the three common drugs that are given in a subcutaneous. So these are all the things that you are required to know. The last type is something called as an intradermal. Remember that subcutaneous needs a needle size of 24 to 26 French. Oh no, sorry, gauge, not French, sorry. Intradermal needs 26 to 30 gauge. Intramuscular needs 20 to 22 gauge, which is technically a pink colored needle. This is a blue colored needle. This is a yellow colored needle. And this one is 18 gauge, which is a green colored needle. So green colored needle for IV. Intramuscular is pink. subcutaneous is blue, and intradermal is yellow. These are technically sometimes called as insulin syringe.
Intramuscular to pink bullet, 20 to 22 gauge.
Yes, sir, 20 to 22 gauge. Right. Intradermal, remember, can you tell me intradermal, any drug that is given intradermally? Yes, sir, antibiotic prophylax. Very good. BCG drugs. This completes your description. Injections are complete. We'll talk about catheterization and end, and then we'll take a break. Let us talk about operation 4 in minor as catheterization. Now, catheterization definitely means, or by definition, is the word catheterization means technically introduction of a hollow tube in an organ, oblique, viscera, or a cavity or vessel for removal of fluid or infusion of fluid. And I will not be getting this definition elsewhere. Examiners will ask you, define a catheter. This is an honors getting question, and people are really in doubt कि boss catheter के definition कहाँ पे मिलेगा. This is how a catheter is defined. It's a hollow tube that is inserted into an organ, viscera, cavity, vessel for removal of a fluid or infusion of a fluid. Organ, viscera, cavity, vessel. That means whenever we talk about catheterization, I am going to talk about urethral catheterization only today. Catheterizations can be intravenous catheterizations, peritoneal cavity catheterizations, etc. Can you tell me when is an intravenous catheterization done? Very simple, sir. For starting an IV fluid, that is an intravenous catheterization. Okay. Can you tell me when is the peritoneal cavity catheterized, or we put in a catheter in the peritoneal cavity?
Peritoneal dialysis.
Peritoneal dialysis, very good. Good. So if you have written the definition, let us come back to the steps of urethral catheterization. Now, when we talk about urethral catheterization, remember that we talk about urethral catheterization, or technically we talk about the male urethral catheterization. Now, the male urethral catheterization, to remember, the step 1 is the consent from the patient. If the patient is awake, if the patient is not awake, there is no question of a consent. You need to take a consent from the family members. The step 2 is proper antiseptic, dripping, and dressing. We have not talked of indications. I will talk at the end, not now. The step 3 is the surgeon, or if you are the operator, wears a sterile gown. Very important. Yes, sir.
আমরা যে মাঝে মাঝে ওই মানে হিমোক্রোম্যাটোসিসের জন্য ফ্লেবোটমি করি, ওটাও কি আমরা এক্সাম্পল অফ আইভি ক্যাথেটারাইজেশন বলতে পারি?
No, phlebotomy. Phlebotomy means you are putting a tube in a vein and you are taking out the blood, na?
Yes, sir.
Yes, sir, you can. But that is, yes, you are putting a catheter in a vein and you are putting a catheter in a vessel and you are taking out the, that is. But sir, in a simple word, 99% of human beings will understand catheterization by this word, urethral catheterization. But in a technical world, the word catheter can mean an intravenous catheter, peritoneal dialysis catheter, urethral catheter, ventricular catheters, many catheters. But for a human being, examiners, you and me, catheterization mane bladder catheterization or urethral catheterization. Now, the step 4.
Last step
Definitely, sir. Consent is this. So, proper antiseptic dressing and dripping. The step number 4 is then a local anesthesia jelly. A local anesthesia jelly mane lignocaine jelly is inserted in the male urethra. The step 5 will thus be after few minutes the catheter is taken from the catheter is taken from the packet in a sterile manner. Step 6, the catheter is inserted slowly till the complete or near complete length of catheter is in the bladder. In a case of a Foley catheter, what is a Foley catheter? We'll talk in instrument class. Remember, a Foley catheter has this shape. This is the balloon and this is the eye of the catheter. This is the valve of the catheter and this is the outlet of the catheter. So it is important that whenever you do a catheterization, you should insert up to this point. If you have completed writing, this will proceed then. Done?
Done.
Very good. The step 7, wait for urine to come in back or catheter end. Okay? In this one, some people say that attach to urobag, this step. Some people say attach a urine collecting bag to a catheter. you can do this and then you can allow the urine to come, or you can allow the urine to come and then attach a bag. Whatever suits you. Some people do any of these. Then comes step 8. Inflate the balloon of the catheter in case of Foley catheter. Now, what is very important that examiners will like to ask you at this step is that why didn't you inflate the Foley the minute it goes to the bladder? Why did you not inflate the Foley when it goes to the bladder? Understand the picture by two things and then you will appreciate what is the dangerous thing about this catheter. In the first picture that I had made, understand that this is the catheter that is there and this is the catheter tip. Understand the next one in this. In both of them, what I am trying to do is that
Sir, you are not audible. No, you are not audible.
Recording stopped.
hello.
Yes, sir.
Right, sorry, I got disconnected a bit. Just a minute. Okay, am I audible? Is the screen visible now?
Yes, sir.
Okay. I think that we ended up at this point. Inflate the balloon of the catheter in case of a Foley catheter. Hello?
Yes, sir.
Yes,
Right. Now see in the first picture, what I will try to show you is,
Recording in progress.
now see the picture 1, or see this picture 1. See that in the picture 1, what has happened when the catheter has been inserted in the bladder immediately when the catheter has been inserted, and then see what has happened. Now, even before little amount of urine comes out, the operator is so happy that he has inflated the balloon. And can you see where has he inflated the balloon? He has inflated the balloon in the urethra, the prostatic urethra, the membranous urethra. So please remember that do not only wait for the urine. 2 points always to remember. Always inflate the balloon of a Foley catheter after the urine has come. Number 1, that will make you sure that you are partly in the bladder. But another important point, please remember the catheter must be inserted till the full length of the catheter is in the bladder, like this picture. This is a right way to do this. This is a wrong way to do this. Please remember that one. The catheter must be inserted till the full length. You are not going to pull or inflate the balloon when the catheter is halfway. Urine coming in the catheter is not only an indication of the placement of the catheter in the urethra. The catheter has to be the full length of the catheter has to go in the urethra. This is mandatory. Please remember this. Catheter का पूरा length urethra में जाना चाहिए, and then you inflate after urine comes. So basically this is what all surgeons are going to hear from you to make you at least give 60% marks. If you have not said this, you will not be getting that marks. If you have any doubts, we shall again have that in the last of the class. Chalo. The last of the steps are the step 9 in this will be replace the foreskin back if the patient has a phimosis. If the patient has a phimosis, you are required to place the foreskin back. And finally, step 10. Remember, fix the bag or fix the urine bag or urine collecting bag to the medial aspect of thigh by a tape, so that the bag doesn't get hanging around. So it is important that you attach the bag with the tape to this part. Okay? So please remember that. If you have completed, please tell me. Done, na?
Done, sir.
What are the complications of a catheterization? The complications of a catheterization are number 1, infection. That means cystitis, urethritis. Complication number 2, urethral injury, which can produce stricture. Complication number 3, periurethral abscess formation. Okay? Number 4, again, catheter stones over long standing catheter placement. So, infection, urethral injury, periurethral abscess formation, catheter stones over long standing catheter placement. purpose. Please tell me if you have completed writing.
Done, sir.
Done, sir. So this is all about a very important part of the operation called as a male urethral catheterization. Female urethral catheterization is taught by gynecology. Simple rubber catheterization is taught by medicine and gynecology, but Foley's catheterization is an extremely important question in exam, both medicine, surgery, pediatrics, and people will be asking you about these questions. So we have completed this big operative part also.
So the contraindications.
Contraindications of catheterization, good one. The only contraindications of catheterizations, good question, sir. I really forgot that part. I should have said that. So the contraindications of catheterizations are technically enough. Contraindications to urethral catheterization are number one, when there is a suspected urethral injury. This is the only one that you are required to know. Why? Because it can convert a partial tear to a complete tear. So, but if you read Love and Bailey and Love says that there should be one gentle attempt at catheterization by an expert. Now, the expert is a neurologist, which an average doctor is not. So, if you are not a neurologist, if the patient has a suspected urethral injury, do not, in the name of the God that you trust, please put in a catheter. In these cases, please do a suprapubic catheterization. Please do a suprapubic catheterization. That means suprapubic catheterization technically means that if this is the urinary bladder, this is the prostate, you are required to place a catheter through the anterior abdominal wall. We will not be reading about this because this is not asked now in MBBS. Previously, this was asked, but nowadays I have not seen this to be asked in an MBBS exam in the last 4 or 5 years. This is asked to postgraduates now. What is the steps of a suprapubic catheterization? Okay, chalo. So this completes your description. Then I think we have completed a major part of this. Catheterization also done. Let us talk about hydroceles and then we go to and take a quick break then. Now, when we talk about
last slide.
When we talk about the hydrocele operation, so let us talk about an hydrocele operation. The last class I told you what is an hydroceles. Now let us talk about the operations for an hydrocele. Hydrocele operation, remember that before I talk about the indication, I should have said the types of operations. The number one is something called as eversion of sac. This operation is technically called the Jaboulet's operation and modified Jaboulet's operation. Now, both of these operations, the basic idea in a Jaboulet's operation is the testis is covered by a layer that is called as tunica. The word tunica means a cover. Vaginal is the word vagina means a blind-ended tube. So, what happens is that in this operation, the testes and the epididymis will remain okay. This is the spermatic cord. The tunica vaginalis is opened like a book and then is stitched behind the testes. So the basic thing is that if it is a book-like structure, so the next time you are looking into a book which is like this, just open the book and this can be the testes, and the basic picture or the basic philosophy of this operation is that the tunica vaginalis is taken behind the testes and you are going to put a simple stitch. Bas. So this is technically called as eversion of the tunica vaginalis. So this operation is also called as a Jaboule's operation. Okay. Now the only modification in this operation has been done is that excess part of the tunica can be excised. That means whatever is excess, the tunica can be large. So we don't need that large part of tunica, that can be excised and then it is everted and a stitch is given posterior to the testes. This is all that you need to know. This is the most common operation that you need to know for a hydrocele. Majority of you are asked, what is this operation? Forget about the steps. Tell me what is this operation. If you have said this, examiner is very happy. If you have completed writing, please say that to me. The second operation in an hydrocele.
So 1 minute.
The second operation in an hydrocele is called as Lord's plication operation. The second operation is called as a Lord's plication operation. Okay, what is this Lord's plication operation? Sir, is always done if the tunica is thick as due to repeated infections. Best example is a filarial hydrocele or patient with an chronic epididymo-orchitis. Chronic epididymo-orchitis. Okay. Now what is important in this operation is that eversion cannot be done because it is so thick. And if eversion cannot be done, then what is done is that if this is the epididymis, this is the testis, and this is the spermatic cord, the tunica is opened like a book, as you have seen. Only problem is that the book pages are very thick. So these are very thick pages, mota. So now what the operator does is that he or she takes a plicating stitch. So these stitches are called as plicating stitches. Now if you have not understood what is the plicating stitches, those of you who know how to wear a dhoti or a sari, the best example, or the parda in your house, the curtains in your house have something called as a plication. So these are all called as plication stitches. And they are done using a catgut stitches, which is an absorbable material. So this is technically called as Lord's plication. If you have completed,
So plication
so the best way of knowing how to do application is that try to wear a dhoti today. That is the way that we can teach application. So it is why exactly, sir. If you have seen the parda, so that is application. You please tell me when you have completed writing. Completed? completed.
স্যার এখানে যদি অ্যাবজর্বেবল মেটেরিয়াল দিয়ে ওটা তো পরে আবার খুলে যেতে পারে মানে যখন অ্যাবজর্ব হয়ে যাবে
No, sir. It will be enough to produce fibrosis. Have you completed? Can I proceed? Thank you. Please come to the third operation. The third operation is something called as aspiration plus minus sclerosant injection. Now, aspiration plus minus sclerosant injection is not recommended. Patients who do not opt for surgery may be a procedure, may be given this choice. I do not give them, but examiners will like to hear this. Maybe the patient is not asking you to do the bigger operation. The patient is saying, "Pani nikal dijiye." First, you are doing this one. I do not recommend this. If you have completed writing, can you go to the steps now?
Yes, sir.
Good. The first step of this is what are the indications of the operation. The indications of an hydrocele operations are a symptomatic primary hydrocele. By this time you know what is a primary hydrocele, which has no particular etiology. Secondary hydrocele, the most important point to remember is always rule out a testicular tumor by clinical tumor markers and an ultrasound. Mandatory. This is the only contraindication that you have to know. Apart from coagulopathies, etc., that are not major, in an MBBS exam, if examiner is asking you when not to do an hydrocele operation, that is in a patient with a suspected testicular tumor. Do not do a hydrocele operation. The third part of this is small hydrocele, but the patient is wanting to get recruited in police or army. This is some examiner's favorite answer. Small hydrocele, patient doesn't have any problem, but he is getting to get recruited in the police or the army. So that is the reason about the operation. If you have completed writing, we go to the next part. What is the pre-operative preparation? So the pre-operative preparation of this is, remember, in the pre-operative preparation, if you are planning for a general anesthesia plan, then take a fitness for a general anesthesia. This is always mandatory. If you are planning for local anesthesia is planned, then at least do a blood for PT, CT, hemoglobin, TLC, BLC and sugar. Because diabetics are known to have a bad complication. Okay? Always rule out allergy to anesthesia or local anesthetic drug. And number 4, if there is a fungal infection, which is very common in this part of the body, please treat the fungal infection before the surgery. Done? Hello?
Done, sir.
Yes, sir.
Sir, can you scroll up a minute? So what is written below clinical and secondary hydrocele?
Rule out testicular tumor by clinical tumor markers and ultrasound of the scrotum.
Okay, thank you, sir.
This is the only contraindication of not operating on a hydrocele. Done? Okay. Come to the third point.
স্যার ফাঙ্গাল ইনফেকশন মানে কি স্কিনে বলছেন না ওইখানেতে হাইড্রোসিলেট
Skin, sir, that region, the genitalia. Okay. The third question is, now the major steps of the operation will be in anesthesia, as I have said. If the patient is uncooperative adult, remember, we go for general anesthesia. If the patient is cooperative, we go for infiltration, cord block, local anesthesia. Completed?
Yes, sir.
Right. So these are the major things. Now, what are the major steps of operation? What are the major steps of an operation? The steps of operation are: step 1, antiseptic